Yeah, respected Chairperson Dr. Jamuna Rajeswaran, Professor and the Head of the Department of Neuropsychology, NIMHANS Bangalore. Madam is a Chairperson, and Mr. Arun, Consultant Clinical Psychologist, Sneka Main Care Center, Thirunelveli, and today moderator Dr. Noor Hassan, Dr. Ashwath Babu, dear colleagues, dear my dear postgraduates, very good morning to all of you. Indeed, it's a great honor and pleasure for me to organize this Evolve webinar. This Evolve webinar has been spread widely across India. So many people from across state used to join these programs. We had attendance more than 200 plus for the previous meeting. So it shows that the quality of the program, and also we are more concerned about that it's useful for the clinical practice also. So today we have a very eminent chairperson, Dr. Jamuna Rajeswaran Madam, and was from a Premier Institute in NIMHANS. And also we have a very eminent speaker also, Dr. Arun, who was graduated from NIMHANS. So Arun is going to speak about family therapy. I think it's very useful for our day-to-day practice. With this very short introduction, I'll hand over this program to Dr. Noor Hassan and Dr. Ashwath to take over. Please take over this, Dr. Ashwath and Noor Hassan.
Good morning, sir. Thank you, sir. Thank you for the opportunity, sir. Very good morning to all the participants out here. Am I being audible?
Yes, yes.
Yes, thank you. Thank you, ma'am. It gives me an immense pleasure being part of this Evolve program after a while. I'm very happy and proud to say that this is the 10th edition of our Evolve program, which has been very successful over a period of time. It is very popular among the postgraduates. At this juncture, it is even more special wherein we collaborate with the clinical psychologists and fraternity. It gives me even more privilege and honor in welcoming and introducing today's chairperson, Dr. Jamuna Rajeswaran. She is Professor and Head, Clinical Neuropsychology and Cognitive Neuroscience Center, NIMHANS. She is faculty in charge of Advanced Functional Neuroimaging at Center of Clinical Neurosciences. He is also the adjunct faculty at NIAS, Indian Institute of Science, Bangalore. He is currently the president of Clinical Psychology Society of India, CPSI, and she is also the member of several professional bodies. Madam has received many awards, and she has been the mentor and also guide for many M.Phil, PhD, clinical psychology, neurophysiology, MCH neurosurgery, and neuroanesthesia thesis. Madam, it is an honor to have you in our session today, ma'am. Now I request you to introduce the topic, ma'am.
Yeah. A very good, I think, good morning to each one of you. At the outset, I wish to thank Dr. Panir Selvam and Dr. Arun, of course, Ashwath and Noor for inviting me. Though this is not my specialty area, family therapy, nevertheless, we do work with family when any individual comes with any clinical conditions. So family becomes the integral part of any. Yes, it's very, very important. And I know what kind of therapy is required in what kind of a clinical condition. So having this topic as a discussion today is a paramount important, not only just to focus on the individual with illness, but also to include family in every step that we give intervention to the patient, because family is important. Especially in our Indian culture, you know that there are so many issues that one can face in the family, be it a religion, be it a caste, be it any kind of issues that can impact the family members. So I think it is a very important topic today. So when we look at family, it is a unit. So when we talk about family itself, we assume that they have a very good interpersonal relationship. Now, when we say family therapy, what does it mean? It is often thought of in a therapeutic, we think of it as in a therapeutic modality. So what do? So what we employ and we recognize, we employ therapeutic intervention when we recognize that there is a conflict in the members and the related other family members. It is an essential intervention in the family system to change the family functioning. So it can be conducted at the hospital setting, it can be during the home visit, or in the community. People can go and look into what kind of interaction the family members have. And of course, the sessions depends on what kind of a problem that the family is facing. So what are the core principles, goals, and techniques? First and foremost thing that one needs to understand is family therapy needed in this particular family? If it is needed, what is the kind of family therapy that one needs to be employing in changing the family pattern? So it can be, you have to identify both positive and negative behaviors which influences and are influenced by multiple relation systems. So what one needs to do is, what is the treatment system that I need to employ in this particular family? How many sessions? Should I conduct an individual session? Should I conduct a group session? Or is it joint session that I need is more effective? What kind of an illness has impacted this family system? All that needs to be kept in mind. I'm sure Dr. Arun will be able to elucidate all these factors in his lecture today. I straight away ask Arun to present his talk, and we can maybe at the end we can discuss about various issues related, and we can conclude at the end. Thank you. Arun?
Yes, ma'am. Thank you so much.
Good morning, everyone. Respected President Dr. C. Thirunelveli and respected Dr. Jamuna Rajeshwaran Madam from NIMHANS, respected speakers, and my dear colleague, Dr. Raswat Babu. It is great to have all these stalwarts in a single table to have a different psychological oriented meeting in the course of multiple psychiatry and neuropsychiatry lectures in between in the evolved sessions. And before jumping into this introduction, I am here to tell the names of the prize winners of the previous session. I'll just read out the names: Dr. Sri Kritika, Dr. Shamini, Dr. Neha Sharma, Dr. Paulomi Laha, Dr. B. Panneerselvam, Dr. Sri Kritika, Dr. Mauridi Gatak. These are all the winners. And I request, in the meantime, I request Naveen to display the names in the chat box. And here in this session also, we have a couple of quiz questions. So people who are answering first and second in the chat box will be selected for the prizes, and prizes will be handed over to the individual before the next session of the Evolve series. Thank you. And here I'm here to introduce Arun Selvaraj. Mr. Arun Selvaraj completed his M.Phil in clinical psychology from National Institute of Mental Health and Neurosciences. And he is a UG CNET qualified assistant professor for psychology. He worked in diverse specialties like DRDO, DIPR, Special Intelligence Cell, and with the Coimbatore City Police and Schools. Currently, he is a consultant psychologist in Sneha Mindcare, Thirunelveli. His areas of interest or expertise are in family and couple therapy, emotion-focused therapy, neuropsychological assessments, age-related disorders. Also had specialized training in family and couple therapy during his M.Phil training at NIMHANS. And he awarded as an inventor at the National Conference on Mental Health and Wellbeing for his works. Also, he presented multiple research papers at the national and international conferences on cognitive neuropsychology and students' mental health. And nonetheless, after getting a degree from NIMHANS, clinical psychologist, working in a periphery setting like Thirunelveli is really a rare thing to see. So I really congratulate him for such a decision to come over the periphery of the state to cater the people with the psychological therapies, whatever we have. Because getting a clinical psychology from NIMHANS is a very, very difficult thing. Okay, and to make them to continue here in the Bible study is also a very difficult task. But understanding the epidemiological demands of the society, he decided to come over here and to give the service in the periphery. Congratulating him again for the same. And here is your online dais for the session. Thank you, Arun Selvaraj.
Thank you, sir. Thank you so much. And very thankful for noticing that, like, the decision which I took to come out to my hometown. I hope my slides are visible.
Yes, sir.
Yes, yes.
Just
Yes,
give
and
me-
keep in the slideshow mode.
Yes.
Naveen, you can mute all of them, and Arun can unmute yourself.
Yes. Yes, sir.
Am I audible and my slides are visible?
Yes.
I really thank everyone and the Evolve team and all the colleagues of mine, Dr. Paneerselvan, Dr. Nurul, Dr. Ashwar, Dr. Aravind, and my research guide, Dr. Jamuna Rajeshwaran, and all the mentors for being in this part. And I'm taking from here on the topic of family therapy and overview. And what to expect from this therapy and what to expect from this, the whole presentation is, these are the few pointers which I would say. So we'll be seeing on what is family therapy and its evolution in India in a very brief note, and then the indications for family therapy when as a clinicians, as a JR residents, as a SR, as a person who is working in an periphery area, like when you can indicate or when you can see that there is a need for family therapy is there, and then moving on, what is the therapy flow, like how does the therapy happens. So including in that, we will be seeing on family therapy intake, assessment, pro forma, and different schools of family therapy, and of course the challenges we face in family therapy setting. And this is the flow of the whole presentation, and the disclaimer is in middle, if I'm not able to like convey the message, it's not audible and you're not getting it, feel free to drop a message in the chat box. I'll be answering it in the lot in towards the end of the presentation. Yes. So, family therapy in India has mostly started in like early 1970s by Vidyasagar in IMH Amritsar. It's currently called as Vidyasagar Mental Hospital. And to understand the family, as Jamuna ma'am mentioned, and also all the clinicians over here do know that family consists of two or more persons who committed to each other and share and resource, intimacy, and decisions and values in one roof or in one emotional connect or bond is called as a family. So family therapy is a type of psychotherapy which includes all the family and which see family as a whole unit. So the assumption behind the family therapy, how the family therapy build up and developed is it based on the belief that the problems of one individual are often connected to the dynamics of the family system. So you can track back from the very golden theories of like psychodynamic, CBT, TBT, all of these theories which talks about how the attachment pattern and family interaction styles. So it traces back to the family system, how it evolved. To understand the evolution of the family therapy in early 1970s, like many psychiatrists and psychologists has begin to look beyond the medical model of the disorder rather than the biopsychosocial model. So where currently most of the mental illness is being treated in the three dynamics, which is biological and psychological and also family and social perspectives. So, in predominantly family and social perspectives, most of the psychologists and social workers, and of course the psychiatrists, step into and deal those issues for the long-term prognosis or long-term recovery. And in 1980s, a lot of family therapy began like more acceptance towards like across India. And NIMHANS is one institute which has a family therapy unit which trains JRs, psychologists, clinical psychologists, and social workers in family therapy. It has a committed 3 months posting in terms of training oneself in family therapy. And later, a lot of researches has been built. Now, the current researchers are more focusing on marginalized groups and different set of problems which arise from the family therapies. This is to have an overview about how family therapy has been rising. Moving on, how to indicate and how what happens in therapy flow is. So you all being medical practitioners and you will be prescribing medications, you will be taking care of all the pharmacological treatment. And despite that, if there is an ongoing family stressors which is significantly contributing to the patient psychopathology, that is one indication where you can take up. It can be in form of like creating, it can be a form of a precipitating factor, or it can be a form of a perpetuating factor, which could be like maintaining the problem. And then that is the point where you can take up a family for a family therapy session. It can be different levels of family therapy. I'll be letting you know that. So family therapy can be used to address various ranges of problems, which includes like mental illness like schizophrenia, BPAD, anxiety, depression, and eating disorders, marital issues, pre and post marital issues, which can be severely the severity may be rated towards like mild, moderate, and severe. And then childhood behavioral problems like non-suicidal self-harm injuries, which is also called as deliberate self-harms, conduct issues, developmental issues like ASDs, ADHDs, and then also the family violences. So these are the things which can be addressed through family therapy. And is this pace is okay, or should I slow down? Any yes or no?
Yeah, we can go in this flow.
Yes. Moving ahead. So what happens in family intervention is, so once the patient is being referred to you as a for family therapy, the first thing is we do an referral intake, and we make a formal contract, which I'm going to discuss in a very detailed format. And then we do family assessments, and then we also do a formulation. And then in middle phase, based on the problems we addressed in the family, we implement different techniques, different perspectives, different schools, and tailor-made the family therapy or family theoretical understanding to the family members, to the specific problem areas. Towards the termination phase, we'll be consolidating all the changes, and we'll help the patients to recognize the newer changes and how to maintain the equilibrium in the family. So the therapy can be like predominantly overview seen as initial, middle, and the termination phase. In initial phase, we'll be taking on the intake. So I'm going to talk on about the intake format. So what happens in intake is, so when the referral came from the clinician or a consultant, you can take around 30 to 20 to 30 minutes, which you can review the file prior to seeing the patients and get all the information available from the case sheet or from the file. Once the informations are gotten, the main aim of the intake session is to briefly understand the family perception of their own problem and their motivation and the need to undergo the family intervention. So apart from this, another major component which all the literature talks about is the therapist fit towards the patient. So does the family therapist and the family also can work along together? Therapist suitability has also to be checked on. So in this, what we can ask for is, we can ask all the claimants 8 explanatory model questions. We can ask about what is their understanding of the problem and what do they name this problem, how does it resolve, and what are the things which can help to recover from these things, which helps us to understand what is the existing family's belief system about the problems. Because it is not it is very common to see that the family attributes all the mental illness towards the physical illness. For example, if the patient has come up with a lot of uh, uh, anxiety related symptoms, they say that they have anxiety like the BP issues, or they have some gastrointestinal difficulties, but they fail to recognize that the so and so person has an anxiety related problems. So what do we ask in this referral intake is, we ask it's 2 questions. Just stick on to these 2 questions, which we ask, what is the problem from each one of the for example, assume that the family consists of 4 members, father, mother, and a brother and a sister. And we ask the same question to each one of the family members, the same question, which what is the problem you expect in this family? And the second question is, we ask, what are the each member's expectations from this family therapy sessions? So expectations is the one angle, and one another angle is what is their problem in their own point of view. Moving on, here I would like to spend a quite some time to just make familiarize in you what are the things should be negotiated and what are the things should be made clear right before the therapy session. The first thing is, we have to keep the appointment timings. And like for example, if the session is going to start, assume that the patient has came into the picture and you have taken the intake, all the informations are taken, so and so person from so and so place, so and so the time was the diagnosis were there, and these are the symptoms, and these are the treatment plan, this is the life chart. All of these information has been provided. And then what we should focus on is we should make the patient familiar towards the therapy setting. So in this, for making familiarizing, these are the key components we have to discuss with them. The first thing is keeping up the appointment timings, and arriving late may reduce the actual time of the session. Like for example, if you are the therapist, you are giving an appointment on Monday 10 o'clock, and if the patient is coming at 10:30, the session just longs for half an hour, not for 1 hour, from 10:30 to 11:30. The family, by this way, we can see that the family is also making an effort and giving a commitment towards a family therapy. And then there is the therapist patient should be informed about all these things. One is, what is the duration of the session? The duration can long up to 50 minutes to 1 hour. This is the timeline of the family therapy sessions. Towards the 45th minute, we can start consolidating. And what if something comes in the end of the session? The patient might bring up something very new in the end of the session. What should I do now? So you can very openly say that we can be discussing the same thing in the next session or the further sessions which is coming up. Well, one is duration of the session, and then the second thing is we have to explain to the patients why the family is seen together. The rationale of the family therapy should be explained to the family members. Prior information should be provided about the session location, which room or which floor or which area. Like assume that people who work in like hospitals like NIMHANS or general hospitals or medical colleges where there will be a lot of rooms, they'll be juggling between the postings. So the family should be informed about this. And in case of any cancellation or postponement from the family side or from the therapist side, it should be informed at least a day before. And then a number of family members expected from the family side, it should be informed to us. So these many people are there. Assume that the family consists of four members, and the daughter might be having an exam, or the son might be having a meeting on the day. So the family members should be informed on these many members will be coming for the family therapy. Or additionally, sometimes they add up in Indian setup, they might add up a lot of family members. Like they might include a grandmother, they might include an aunt into the picture, or the neighbor into the picture. It should be informed priorly. Communication pattern decision should be goal directed. There should be a habit of turn taking should be there, and there is no interruption should be made by the other family members when one person is talking. And listening to each other members in the room is very very important. So you can see, like I have you can see in the family sessions, when the couple is talking or when the one person is talking, the other person just easily engage in the mobile phones, or they just don't listen to them. The same pattern what they are doing in the house is can be replicated in the house, in the therapy room. So which gives us an emotional understanding about how the family members are reacting in the family therapy session as a replica from their home. And few other guidelines are, there should be no verbal arguments or fights during the session. To avoid such things, we can also make a no violence contract. Like you can give a written format, or you can give a sort of disclaimer to make the couple to sign, or to make the family to sign on it, like so and so things will not be done in the sessions. And as I said earlier, if the issues are coming at the end of the sessions, you can like very openly say that I do understand about the issues. We'll be addressing this in the upcoming sessions or the later sessions or the next sessions. And there are more chances the patients might be insisting, like, I'll tell only one last thing. Can you please listen? This is only one thing. And sometimes they want to like come alone, like, can I talk to you personally? I have something to say to you personally. So that are all not advised in the family therapy sessions. So informing the clients about confidentiality of the contents, the sessions, and the record keeping practices, and also the supervisions. So you can inform the clients about like who you are discussing with, and who are the co-therapists, and who are the therapists, and who all the people who know about the family therapy progressions. Assume that there is a family of 4 members, and there is a daughter who has been diagnosed with paranoid schizophrenia, or like a prodrome of schizophrenic symptoms, and or she might be having mixed anxiety and depressive features. She might be seen by an individual therapist alone, and individual therapist might know about what is happening in the family therapy. So this should be informed. The family should be know about what is happening between the treating team and who is addressing what. That should be informed. And these are the major guidelines has to be made clear in the intake session. This is the first and foremost step of family therapy session. where we are talking about the referral intake and the formal contract. Is it clear? Any doubts so far?
No, sir.
Thank you. Okay, moving ahead. So what happens in therapy room? How does the therapy room looks like is, in the therapy room, assume that it's not like how you see the individual in the therapy session. So it's more on one-on-one, where you will be able to get all the verbal and non-verbal cues, and you can be more you by I mean like as a therapist. As a therapist, we can able to be more mindful what is happening with the patient and what is happening within them, and all we can monitor all the verbal and non-verbal cues, and we can able to connect with what happened in the previous sessions. But this might not happen in family therapy, because family therapy has at least 3 or 4 members in the session. So as a single-handed person managing 4 to 5 members in a therapy room, it can be emotionally and cognitively overloading. So having a co-therapist which helps us to divide the goals between what is your role and what is my role. So for example, the main therapist might be noticing all the emotional components, and the co-therapist might be just noticing on the index patients and his or her interaction pattern with the family members. And the therapy room might be a little bit more spacious and give a lot of chairs, and keep different types of chairs, and give some air, because keep some tissues, keep waters, give breaks, have plug points, keep some areas to put charge their phones and make it silent. All of these things should be made available in the family therapy room setup. Moving ahead to the family assessment performer, which is the vast area to focus on. So the domains which is focused on family assessment performer is, what is the family structure, the leadership patterns, role structure and the functioning, communication patterns, reinforcements, cohesiveness, and adaptive patterns. These are the areas we have to be focusing on the family assessment performer. Then this is the screenshot from the performer. And in talking about family structure, it talks about 3 major components. One is generational genogram, which should include of 3 generations, current living arrangements, and then boundaries, and then family developmental stages, which is developed by Duvall. So this is a textbook example of how a 3 generational family genogram looks like. And I do know you all familiar with all these squares and circles, which is squares are males and circles are females. And some of you might know about the relationship. I'll be explaining on all of these lines. So genogram related to gender is, all these squares are male, all these circles female, and the squares which is crosses diamond is pet, and the transgender and transgender male to female has to be noticed like this, which is you can see it in the slide. And then regarding children, the biological children will be indicated in the straight line, adopted will be dotted, foster also dotted, pregnancy is a triangle, and these are twins and triplets. And there are family symbols, like these are the family symbols which indicates about the relationship. So which is like marriage, separation, legal divorce, and all of these are the different types of relationship where family can bring up. They can say that my wife is having an extramarital affair, or my husband is having an extramarital affair, which is not right here. And sometimes we wonder how we could mention it in the picture. So we can use such symbols, or we can indicate using this into into the family genogram. 1 minute. Yes. So there is also a indication for emotional relationship, where how they feel towards each other person. So you can see the initial example I have showed about the fused relationship, hostile, or hostile or conflictual, manipulative. I would have shown in the future few of like the previous slides. There is also abuse, physical abuse, emotional abuse. And these are the few indications where you can take up and mention it in the family genogram. Now, and then there are medical condition has also been noticed. So these are the few medical conditions. So this is one of my case, which I have done it in my M.Phil the therapy submission as a part of my course. So where you can see these are the mental illness, people who are suffer from mental illness, and I have indicated here. And these are the people who have physical illness and substance use disorders. And there is close relationship, which is mentioned in two stripes of red color, and there is this enmeshed and infused relationship, which is by three colors, and then conflict, which why we have to do this genogram is, this gives an overview about the family, and it helps us to understand what is actually happening in the family and which part of this family is actually dysfunctional currently. So this gives us an understanding about like where we have to start working and how the family as a unit is being settled down. And the second part we have to talk is which is boundaries. So we all might use like, can you have some boundaries with your friends, or can you have boundaries from your work life? So what does boundaries mean? This boundaries is a function is to protect the differentiation of the system. System by they mean the family. The family, there's the mother, daughter, and the like it can be the four people in the family, and allow for the emergence of the structure. Where if the boundaries are well formed, the family inside the system can emerge on its own. The boundaries are the rules defining like who can participate in the system and how they can participate in the system. As you see here, so assume that the middle one is us, and we can see like who can participate in our first form of support, and it extended to its extreme. So the boundary should be clear, and what are the boundaries are there is the boundaries can be clear, it can be diffuse, enmeshed, and closed or rigid. So clear or open boundaries are, it is well defined and it allows the subsystems. Subsystems means in a system there can be a parental system and there can be a sibling subsystem, there can be a couple subsystem. So the subsystem members are allowed to carry any functions without any interference, but still allow the contact between the members of the system. They have the clear boundaries about what they can talk and how they can talk and when they can come in. So it's very mutual and it is very understandable. And there is diffused where there is a distance is slightly there. The boundaries are a little blurred where sometimes opinions are come from them and they have to take it, and whatever the emotional comments they are passing, it might directly affect them. So all of these things can be a diffused boundary system. And then there is enmeshment, which is little interpersonal distance where considerably blurring of subsystem, where it is like more of a fused, where they'll be like confused between they might say like my aunt is like my mother, my grandfather is my father, and I see like all of this is like mixing the relationship dynamics and then fusing it with more complex in understanding of relationship. And then there is a closed or rigid, which prevents an individual from members having a predictable or a meaningful contact to each other, where you can see it in a refrigerator mother, which is in schizophrenic symptoms, whereby they are very cold and they can't able to communicate. Or you can see similar sort of communication pattern in a patient with borderline personality disorders when they are depersonalizing, or they're not like they're not ready to talk, or they have very rigid communication. I don't want to talk to them. They were very in a revengeful mode to talk. So these are the some boundaries which has to be noted in the assessment pro forma. And then there are different classifications of how family life cycle stages has been grown. So one of the popular theories we are going to talk about is Duvall's 8 stages, which is he proposed in 1971. So the assumption behind this Duvall stages is he assumes that the family stages is very traditional, it's nuclear, and it's an intact family where it moves from one order by order. In this stage, all the family members has certain tasks and certain difficulties, and this has to be ruled out. So assume that the family can come in any time. They can come in a very premarital setup, or they can come in having a child who is in adolescence, or the family can come in little older, like the sons and daughters are got married. They can come as a old age couple. So what we have to do in this time is we have to understand the family in a very structural way using this dual stages. There are 8 stages. I want to read out all the stages, which is first stage is married couple without children, and then childbearing families, families with preschool children, families with school age children, families with teenagers, family launching young adults, middle-aged parents, and aging family. So these are the different stages. And prior to married couple without children, we can also add a courtship period in these stages. So I would like to say what are the tasks and what are the difficulties in each stages, which in a very brief format, because married couple with children is like a formation of a marital system where they have to come out from of one different family and have to adjust with the new family, friends, and set of belief systems, and establishing a mutually satisfying a marriage. This is the task which has to be fulfilled in this stage. Once this task is got over, they might move into the next stage. And what are the difficulties they might face is they have significant difficulties in shifting from one family to another family and adjusting to their belief systems. The new couples may be like afraid of the set of limits given by the in-laws, difficulties in formating like adequate relationship, high expectations, economic changes, changes in rules, who is going to cook or who is going to wake up or who is going to earn, power arrangements, high expectations from each others. So all of these things has to be settled down uh, in like couple of 3 months to 4 months. If it is not, which might be indicating a significant difficulties in the family members. Moving ahead, yeah. Then there is the childbearing practices where the families of where the families has to do a task of adjusting marital system. Like they have to make babies and then taking parental roles, and including the extended family members like mother-in-laws, mother or extended aunt or the sister. They have to get into a role of parenting to support the family. This is one part of things. And then the difficulties is the parental subsystem might have lesser time to focus on each other, disengagement between both of these people, changes in lifestyle. They have to focus more on child, and the emotional involvement between the couple relationship might go down. These are the some difficulties which might be faced during these stages, which can last for 0 to 2.5 years. And towards the third stage, as stage by stage goes, there are different difficulties which is faced, which is family with preschool children, which is a major chunk of population who might come up with a newer diagnosis that my child is having so and so problem, is acting so and so, where they have to adapt to the school needs, coping with energy depletions, and then lack of privacy, preparation of child to go to school, pre-academic skill training. They have to sit and do with homework. All of these things they have to focus. And then the difficulties they might be like planning the gap between the second children or the third children, financial difficulties, sleeping arrangements, more attention, love, and care towards the children than the spouse, inadequate quality of time spent by working parents, difficulty in understanding the child behavior, and increased responsibilities in parenting, couples, family dynamics, and the couple might also have to see their own parents and has to meet the financial needs. If there is sibling, they have to focus on there, and difficulties are like fitting into community, all of such. So due to time constraint, I'm just moving up a little bit speed on these stages. And family with teenagers are there, where a lot of emotional problems might come up in such stages, because this is the time they might be launching out. And then there are families with middle-aged parents where they might feel a lot of emptiness syndrome, where the parents and children are got married, or if the parents are having a financial support, then there is no issues, or they have to depend on their own children to be have satisfy their own needs. And towards the old age, they have to manage with the death of spouse, or feeling more lonely that children are not alone, or they have a lot of experience towards their previous life experience. They might have a sort of remorse or happiness about their previous life incidents, feeling lonely, health issues. All of these things has to be taken care. So assume that there is a family and which is sitting in the stage of like you can say like in the family with launching young adults. And till here you have to take a family life cycle stages and give an impression of what are the tasks the family done, and what are the tasks the family had still having a difficulties, and rule out that and build your hypothesis based on that. This is one area of an family therapy intake. The another area is leadership patterns. Look at this power structure in the family, who is deciding, and their attitude towards the opposite gender, authority, acceptance, and the normal functioning levels and decision making process. Is it more autocratic or is it more democratic, where they discuss about things? And there are more families which comes up in this locality, like they just decide and we have to follow. And these are the things which face a very higher difficulty in an understanding between cultural beliefs and also coming up with therapeutic interventions. Role structure and family member in each one units, we have to see what are their roles and what are their responsibilities in day-to-day life, and what are the conflicts they are facing in day-to-day life practices. We have to see it. There might be a multiplicity whereby like a male has to do all the works, groceries, work, breadwinner, just drop the school, drop to the wife, and everything has to might do. Like we have to check what are the roles and responsibilities they are taking in a day-to-day life. And communication, this is one important part to just focus on. So who speaks to whom? You can see in a therapy session, even a seating arrangement, you can understand that where does the person sits and next to whom, and how they are arranging it, and how they are engaging when the other person is talking in the family members. And what is the noise level and the equality of participation? There are most of the families where they say, you shut up, I want to talk. Like, you just don't talk, just don't listen to her. Well, whenever the person is talking, they might just go down, or they don't want to actively listen on it. And look for the communication. Is it direct or more indirect? Sometimes there will be more paradoxical communication, which is like sometimes they say, I'm dying, like I will visit you unexpectedly this evening. The lot of mixed experience of emotions they might be transferring it. And there is one more thing, which is switchboard communications, where you can see this kind of communication in most of the dissociative patients, most of the depressive patients, where the couple might be using the child as a medium to communicate such things, or the husband or the mother might be the moderator between the child and the father. Like they are acting like a switchboard where it doesn't communicate very easily, where there might be a very rigid boundaries between the parties, which is not actively engaging in the communications. And then how they are expressing their affective status, which is their feelings and how they want to express out of it, and all their like positive and the negative feelings, which is love, happiness, joy, and they're not okay, feel disappointment. All of these things are how they are sharing. These things has to be understood. And reinforcements, which is what type of reinforcement strategies the family use to keep running, like taken in, which is this is socially acceptable. We have to see all of those things. And then cohesiveness, and this is very very important in this cultural setup, because the cultural is run through lot of rituals in religious practices, lot of rituals in customs, lot of rituals in religion, castes, locality. There are a lot of rituals which has to be understood. It's according to your locality. It's better to have a good understanding about what sort of rituals certain group of people or certain locality of people do engage, and does the family is doing it? If not, why? So all of these things has to be understood. Usually this cohesion is expressed in a way of like, I'm so much in love with you, I'm in like 10,000% love with you, or they express in sort of commitment, or in sort of the degree of intimacy they show it in interpersonal dimension. And then adaptive patterns has to be noted, where how their family has a habit of resolving the conflict, and what are the social systems which come into the step. For example, there are most of the families which goes to their own parent house to resolve the conflict, and there are some families which goes to court directly. So we have to see who's the social support system which is to the family system which we are seeing right now, which can be broadly understood as primary, secondary, and tertiary. Which is primary is support from immediate family members, secondary is relative, friends, and neighbors, and tertiary is hospital, voluntary, and NGOs, and religious institutions. So how the crisis can come in this finance? There are two types of crisis which can come, and one is vertical stressor and one is horizontal stressor. And I think we can have a question here, since I've been talking for some time. I would like to take a break and ask questions. No, sir, is it okay?
Yes, you can go ahead.
Yeah. So, who is the first person in India who has spoken about family therapy? And little bit clueless, it's from Amritsar. Okay, we got some responses.
Yeah, next question.
I'll hold for the next question. Yes, and I just want to check the participation.
Yeah.
Okay, moving on to the crisis during the life cycle stages. One is vertical, where it has to be think in aspect of system levels, where it is socio-cultural, political, economic, and then there is community, and then there is extended family and the close family members and the individuals. All these families, these different systems has family patterns, myths, secrets, beliefs, origins. They have their own belief system. So these are the vertical stressors. And then there is horizontal stressors, which is which happens in time, which is more developmental, like life cycle transition. And there is it can be predictable, which is developmental, and then there is which is also be unpredictable, which is like early death, some chronic disease or accidents or death of someone, which is horizontal stress, which is unpredictable, which is mostly independent on the time. And the vertical stress, which can be understood in the format of it's transgenerational or a cross generational perspective or in a communal perspective. Moving on to the schools of family therapy, and there are many schools. The common followed schools are structural family, strategic, emotion focused therapy, CBT in couple therapy, Pavan, psychodynamic, solution focus, in which I'm going to talk about only 2 or 3. And the other therapies are million family, contextual, Gottman method. So moving on to structural family therapy, it was developed by Salvador Minuchin and Charles Fishman. So their work towards family therapy is very nice and very rational to understand the family's interaction pattern. So this is the first key concept to structurally understand what does happen in family. The key components is they understand the family's interaction pattern, how the family is organized, and how the family is working towards the symptom reduction, and emphasis on the whole family and its subunits, like how the system functions. They see, assume that if the system is the 4 wheels in the car, they see all the parts of the car, and how the therapist joins with each unit in the families, and they come out and they help them to transform, and say they help them to visualize what is the dysfunctional pattern. So where we can use this sort of structural therapies, we can especially use in juvenile delinquents, alcohol use patients, and anorexic patients, and people who are coming from low socioeconomic status and cross-cultural populations. So because since the therapy is focusing on a lot of interaction patterns, there are high chances the opposite person might be misinterpreting or not getting or getting into a negative interaction style, so that it gets a lot of emotional turmoil picture. So that assumption behind it is the pathology develops in this way. And then there is strategic family therapy. It's more short-term treatment, which is developed by all these 4 people, which is John Weakland, Don Jackson, and Paul and Richard. So these therapies focus on telling the behavior strategies which helps the family to define and reach goals, where this can be used in more of chronic issues, and also in eating disorders and substance use, for which is having high relapse uh, 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 high relapses in the cases, where we keep a small goal which is reachable, and we help the patients to go there and break the pattern which they are doing. Which you can see it in OCPDs, you can see it in BPDs, where they might be having a specific pattern of doing things, and we try to stop it. And first and second order changes has to be understood, like which is like from each one of the unit in the family, the changes is being expected. And moving on, there is behavioral methods which use all the behavioral schools, which from Pavlov's classical conditioning, Watson's, Thorndike, Skinner's, Bandura's, all of these theories takes up. It predominantly used in helped in like we therapists might joining with the parents in terms of helping how to efficiently parent or how to efficiently engage in such behaviors. It majorly taps on the maladaptive behaviors and the not focuses on the underlying cause. It doesn't go depth into the why it started, how it started, and all the pathology doesn't go, because uh, the patient's amenability might be less. So that is why we might take a more of behavioral methods, and it should be targets of the changes and not record to treat the entire family. So assume that there is a child who has a behavior of demanding, and we notice there is some personality dysfunction in the parents, and we might not focus on that. We just be focusing on just the problem behavior and just work through the parents. That's it. And in this therapy, the therapist is the expert who teaches, who collaborates, and then coach the person. And moving on, psychodynamic therapy, which is based on the Freudian understanding, where it emphasizes on it takes quite a long time. It's a long time therapy sessions. And the amenability of the therapy is the patient's reflective capacity is very important. They must be more emotionally expressive and they could able to engage in an emotionally engaged conversations. It predominantly focus on the past issues are still like focusing or are like might be creating a problem in the current interaction pattern, the early life experiences and the interpersonal and intrapersonal dysfunctions, which is can be also understood in the object relations theory. The suitability is the patient who are very reflective and able to be communicate their own thoughts, their own connections with their own emotions. That would be the more beneficial in this lines. And for you all to take home since you are practicing, so to talk in disorder specific interventions in schizophrenia, the first and foremost thing you have to focus on is the family's expressed emotions. There are a lot of research evidences which states that families expressed emotions are major cause in maintaining the schizophrenic symptom, which is the classic communal research has been done. And then there is communication disturbances in the families where they sometimes don't understand what is schizophrenia or why does it happen. So, taking a psychoeducational intervention about the importance of treatment compliance and its prognosis, management of positive and negative symptoms, which gives the family and sort of an empowerment in terms of understanding the patient and the treatment importance. And you can also work with the patients in terms of by reducing the adverse family reactions, like using very simple strategies like not avoiding the critical relatives and helping the parents to expect uh, reasonable expectations from the parents. This all the things will reduce the stressors, which is still maintaining the diagnosis or still maintaining the pathology. And we also help the family with in terms of being more resilient by building them in crisis interventions, skills training, and emotional support. All of these things might help in schizophrenic patients. Might be a family who has a patient who has diagnosed with schizophrenia, and then BPAD in bipolar affective disorders, where we can teach the family on to early recognize the signs and symptoms, and we can explain how this fluctuations happen and how does it goes to the both extremes. Early interventions in the newer episodes, treatment compliance, anger management, and feeling of frustrations, and how to deal with such mood symptoms we can be taught. And then there is depressive patients where oftenly referred to therapy setup. So usually the depression cause might be different, like the causes might be due to interpersonal or due to early life experiences. In most of the cases, interpersonal conflicts which might creating an depressive features can be understood in a more emotionally enriching way. Like we can understand through attachment patterns, family conflict, addressing the ineffective communication patterns in the families. And we also can think about what are the misbeliefs the unit carries or the family member carries or the faulty cognition which is still negatively maintaining the communications. And then we can also address the childhood disorders like contingency management, making contingency management, psychoeducating about the conditions, validating the patient experience. All of these things will be more helpful for the parents. Like once you start validating what is the good things are they are doing in the parenting and what are the things they can still improve on it. Towards the termination of the sessions, what you can do as a therapist is all of all of these things which I have spoken earlier, which can be come into the middle phase of the session. And initial phase, we have spoken about how to do an intake and what are the things we can make an inference and we can make an hypothesis. And middle phase, based on the problems, based on the problem nature, we can take up any schools of or any techniques into the therapy setup. And towards the termination, we can consolidate all the findings and the emotional insights where the family has got throughout the sessions and help the patients to recognize the changes and prepare them for the newer changes, and also definitely make sure that you are having a booster sessions after 3 or 6 months to see how the family is currently functioning. And before moving on to the challenges, can I have questions now? I'm towards the end. I might take next 5 minutes. So the next question is, who developed the structural family therapy? There are two authors. It's so nice to see so many responses on a Sunday. There are very few persons who are mentioning the full and the correct name.
We can take this, right? Salvador and Fishman, we can take.
Yeah, Salvador Minuchin and Charles Fishman.
Yeah, so
Yeah.
Angeline and Rohini.
Yes. So next question is, this is very simple question, so be ready with your keyboard because I don't know like where to ask question. So what are the two types of stressors which can happen in family life stages and how we can understood that? Okay.
Yeah.
I think it's done. And there is a following question on this, which is the fourth question, which is which of these stressors which involves transgenerational stressor or the communal stressor? So I'll answer all of the things which I have asked before.
For
There
this
is one more.
question, what is the answer?
Yeah.
Transgenerational.
Yeah. So it is vertical.
Okay.
And for the previous one, which is there are two types of stressors, which is horizontal and vertical. Horizontal is more on time, which can be predictable or unpredictable, and there is vertical, which can come on more family beliefs, transgenerational, all of these things. There is one last question. Who proposed the 8 stages, life cycle stages? Okay, my questions are done. So Duvall proposed the last, the 8 stages. Okay, there's time running. I'm going back to my slides. Thank you for your active participation. I'm so happy to see a lot of messages. Okay, the common challenges we face in therapy setup is in India, a lot of family is living in a joint family setup. Even though they live in a single family setup, all of these joint family setups are like they come across and they influence into the couple subsystem. So one is transgenerational issues, where sometimes the people come as a joint family, like 7, 8 members come to the family therapy session. Sometimes we don't know what to do with so much upload in the family in the sessions, and then it can be in that way or it can be in the other way, like forced dependency or interdependency rather than autonomy, where they might go to their parents to ask what to do, or they might go to their extended family members to do what to do. So where still the different family beliefs colors our own the clients which who are sitting in front of us, and the therapist might have a familiar understanding with the religious customs, practice, beliefs, and rituals, which is the one important reason I have came to my hometown, which is the locality, to understand what is happening with my own people. And then there is economical causes. Families mostly in upper middle socioeconomic status or higher socioeconomic status usually continue family therapies because economy to take up the family therapy session is not a big deal for them. And then there are a lot of dropouts which has been seen in low socioeconomic status, and also like in middle or lower middle socioeconomic status. And most of the people are not aware about there is a service called family therapy, and you can address such things in those setups. And process related difficulties as a therapist, you might also can go through a lot in the therapy sessions because the patients who are sitting in front of you might depict a similar or closely similar scenarios which you are also experiencing. So that is the reason why the discussions are very, very important for a family therapy sessions. You should have a co-therapist, you should have a discussant, and you can go for every sessions and to discuss about what is the plan. And I'm done with my presentations. And to just consolidate all of these things, so once a family referral came, you have to take a referral and you have to review all the files, you have to review all the information. I'm just summarizing all of these things. You can keep your pens down, just listen. And you can take an intake which addresses what is their expectation from the family therapy and what is their understanding about the problem, which is one. All the family members should be seen in one setup. That is like, no, my wife might come later, I'll come to my family therapy. No, there is one person is not there, which is not advisable. All the family members should be present, and there are certain guidelines where they have to maintain the time appointment, where they have to be mutually respective. They give turns. All of these things should be made clear before the therapy starts. And once the therapy starts, we start with then family assessment pro forma, where we go through all the 7 domains of, which starts from Genogram, which is 3 generational, their family origin, beliefs, and then we go through. I'll just also show it so that it will help you to visualize also. Yes. So, which also includes how the family is being understanding, and then family developmental stages, which are, you can use the Duvall's 8 stages, and then there is leadership patterns, role structure and functioning, communication patterns, reinforcements, how the family is more cohesively functioning, and adaptive patterns, like in case of problem comes and how they came up. So based on this, we build a lot of hypotheses how this family is functioning and why the problem is still persisting. We, as a therapist, we identify what is the dysfunctional pattern, and we start presenting our understanding towards the client. And then we, based on the client's nature of problems, we take different schools. We take different perspectives in understanding the problem, and we implement all of those things. And towards the termination, we explain what are the changes they have gone through, and we prepare them uh, uh, for the further for the new beginnings. And we of course don't forget the challenges, and supervision is very, very, very important, very must in family therapy sessions. Without a supervision, a family therapy sessions can be go like here and there, and make sure that you're having a supervision sessions for your therapies. And thank you so much for your for this patient listening. And I'm very happy to have such big crowd, and this is the first time I'm presenting to a psychiatrist population. And thanks for giving this opportunity, Dr. Selvam, and all the other panel members. And I can take a few questions also.
Yes, thank you, Arun Selvaraj, for a wonderful presentation. So here we will start the questions. And before that, I have shared the winners' name list in the chat. So people can type their phone number. So we'll call them and we'll hand over the prizes soon. Because unlike the previous presentation, we have many psychologists here. So for other doctors, we can trace to the medical college. For psychology, we'll be feeling difficulty. So they can share their phone numbers and we will connect with them. And starting with the question. So here, so example, I am in a family session. Okay, I am a therapist. So I can cut down the family issues into three ways. So number one, the expressed emotion issues, number one. And second thing, the in-between couple, issues between the couple. And third thing, between the parent, okay, and the children. So these are the three most common things that we are facing. Okay, so nobody's coming to the therapist that we had a big family conflict yesterday, so we want to have therapy. So nobody's coming with that indication, because for a joint family, after they become nuclear, the things will be settled. But cutting down the discussion, so the three important people who are coming are the patient with expressed emotions, between couple, and parent with children. These are the three ways we are seeing the cases. So my question here is, so whom to interview first? Whom to interview first? So example, parents coming with children or adolescent. So couple coming, so husband and wife. So whom to interview first? So, and where we can start, because I'm not asking any deep question related to a particular contextual issue, or rather whom to start with, because in a couple, if I start with the husband, then and the wife may feel judgmental that I am just aligning with the concerns of a husband, being a male. So these are some kind of issues. So my question is, whom to start with in this context? Whom I have to interview first?
Okay. So if I'm understanding the question properly, there is a family which has different issues, and like there is a family who came up to consult, and there is one index patient in the family to whom I address. So I would start my understanding with like if it is a practice like a hospital like NIMHANS, where it has a dedicated unit where they see only family, where they see only patient, where they see only medication. But most of us working in a very periphery setup, we don't have that luxury to just hold or like to make the patient wait. What I've sort of modified is I take the index patient who came the what is the file name is on. I just call them, I'll take them, and then I do an intake, and then I'll bring into the family to the picture. And if it is a case where the patient has been just referred for family therapy and it has been previously seen by any psychiatrist, and then there is no way that I'm going to split the family across. If the patient is demanding, like, no, I want to tell it in protocol, like separate, or it would be better if we hold the family together and we see the like the family as a whole unit. Ma'am, if you want any, you can please comment.
I'd just like to put it across.
Yes,
When two couples, that is the older couple and the younger couple, and the index patient is being referred for family therapy, it is always better to keep all of them together and just get their views and then explain to them that we will be doing it individually or jointly with the couple or jointly with all four of you in the future sessions, so that they don't make the impression that I have been sidelined, I have been given importance, I have not been given importance. So you have to make it very clear you are a neutral person sitting there addressing the issues in the coming sessions, maybe jointly or maybe individually.
Yes, yes. Thank you, thank you. And Ummu Ayman raised the hand.
Yeah.
She can ask now. She can unmute herself and ask. Okay, it is getting late. Then, is there any other questions from the participants they can ask?
So to make it more precise, I'm just sharing few like these are the Kleinman's explanatory model questions. You can use these questions like since you're all busy in OPD where you have to go like back to back. So all of these questions will help. Like what do you call your problem? Why you think which just gives where we have to start from it. Some family just come up that they just say you just have depression, but if you see the file, the diagnosis will be schizophrenia. Some family just say, there's nothing, there's nothing, it's just acting out. If you see the file, there may be dissociative disorder. So you just first understand what is the family's belief and then you start intervening. You just don't start. That's all. There is a question in the comment box.
Yeah, so she's asking about she's asking book that she can refer or the participants can refer for.
Yeah, so there is a book.
And second thing, a good place to do a observership on family therapy.
You can come to Sneka Hospital. We can provide you internship, one, where I will be the supervisor and Nurul sir will be the academic coordinator. So you can come here. And the good book to read is you can read upon IGNO's material. There is IGNO's material which is had a high contribution from the faculties of NIMHANS. Dr. Anisha Shah has worked, and a lot of psychiatrists has worked in that one specific material. So I'll if possible I'll share that also. Give me a minute. Yeah, with that I can like take in. Is there any questions?
I'll just come in. There is a 3-month internship that is provided for M.Phils who have completed their M.Phil, or even the psychiatrists who have completed their MD in the family psychiatry. They will give you training for 3 months. So you will have to apply before, and then they will tell you at which month to come. The timing is decided by NIMHANS faculties. So there's another training that is given.
So I have shared the material, ma'am, in the chat box for whoever is want to take up. Is open source is available. You can check it in the IGNO website. It's not something secret and all. it's very accessible because the material which has a lot of inputs from the NIMHANS faculty, so it's more reliable.
Okay, if there are no other questions, then we can go for conclusive remarks. Ma'am, Jamuna Madam, so share your couple of words.
Yeah. Thank you, Arun, for the brilliant talk. And you made it very educative, very simple. It seemed to me that your 3 months of your family therapy, you put it in a nutshell and just disseminated to the participants. However, I do have a little bit of contribution in this whole. One thing, the first thing that one should understand is the textbook gives you the steps, textbooks gives you the guidelines, but what is very, very important is the process. How does it proceed? Should I follow the textbook method of these guidelines? Yes, you have to be aware of the guidelines. You have to be aware of the steps that you need to follow. But sometimes, like Arun also said in between, some issue might come up. Please don't negate that issue. If you do not resolve that issue, what can happen is the preceding sessions will not be very effective. So you have to just jump into that issue and see how you can resolve that issue. So this is the process one needs to follow. If you do not follow the process, there is not much of a gain that the person will have with this family therapy. There are many things that one needs to keep in mind while doing. Arun said about the confidentiality. Yes, confidentiality, they sign it with us. I can just quote a case. What happened is we would take the confidentiality from both the couples. This is with regard to the couple I'm speaking. And then what happens, since they live in joint family, the couple went back. The husband narrated whatever happened in the session to the parents. Now, what happened? The wife was very, very unhappy because everything was disseminated to that became an issue in the family. So you will have to be very perceptive. What is that next session? The wife was very upset. Of course, any amount of probing, they may not say immediately. Then later on, it was understood that this, whatever happens in the session is transpired to the parents. Parents also, what they will do, what suits them, they take it. And then again, they blame the person who's probably the wife is the victim there because she's been given more importance in this session. So what happens next time? They'll say either they tell them not to go for the session or the wife gets into a depression. So all this needs to be taken in mind. And with the advancement in technology and kind of life changes that currently we are facing, there's a lot of sexual issues. And as a culture, we don't speak about it. We don't probe into it. Many a times, that is the root cause for their problem, especially in couples. So somewhere along, look into those components, because there are cases where they'll come back, like Arun said, they will be either looking into their mobile, not interested, because the bonding has never taken place. Sexually also, they're not involved. So these are, or it may be a sexual dysfunction. So probe into these aspects also, because that is one of the other key issues which the culture doesn't allow us to probe, and neither the patients are very comfortable speaking to us. And then, yes, he spoke about different modules that is being given. He spoke about the genogram. These are all essential ingredients for family therapy. But how it proceeds is only you know it. You are empowered with all these kind of information, and what information I need to give importance in this session. You may plan out a session very differently, but what you're really doing in the session is very different. And that's how it will work. It cannot, one size doesn't fit all. So you can't take down from the book and say, okay, this session I'm going to do this. No, it doesn't happen at all. Children may be the cause. For example, the previous day, the school has given a very bad report about the child. They may be upset about it. They might have had a fight regarding, oh, you haven't given enough attention. I have not given enough attention. And they come to your session and you're talking about how you should be compatible with each other, what you should do. First and foremost, the resolving that child's issue is another important thing. That session takes the precedence. So you will have to address those issues. You should understand when they come in, what is that a few minutes that you spend with them asking what happened yesterday, how was the day for you, somewhere along they will let you know, yes, yesterday we had a fight because my child did very badly in school. Now that should be your focus, not what you go with the textbook. So that is when you will see so much of change, and the rapport is very good once you address those kind of issues. And never take sides for whatever it is worth it. Never take sides with either of the, but by and large, what happens, we are a little biased while we are in the therapy session, but keep a check on yourself so that, none of the partners or the members of the family therapy should perceive, oh, they're taking my side. Then your whole idea of family therapy breaks in. And then today we know that the roles are very, very diffused, both male and female. And if you see the kind of problems that is emerging today is because of this role diffusion. They say, I'm also earning, you're also earning, let's share the roles. So how are we going to address this? That may be the major cause for the problem that they're having. And if we don't address that problem, you have not addressed what the crucial problem is. So we need to address those, because if they're living in a joint family, obviously, with no gender difference, I'm saying the males are given that kind of a freedom not to do what the females have to do. So those things also one needs to, because today even the child rearing practice is such that both males and females are reared equally. They are not said you should do this role, you should do this role. Maybe at my time, yes, we were told that this is your role, and that is the male role is very different. So even that is another important issue that will come up. And with the transgenders coming in now and accepted in that is another major issue that is coming up in the family therapy. Now, I do not know if there is a textbook which can address this. Now we have to evolve at addressing this kind of an issue because people are coming out in open and saying, yes, I'm this kind of a gender, how will you address my problems? So please look into those aspects also when a person comes to you as a family, as a couple, all this needs to be addressed and understand the problems. When you look at the clinical condition, is it the clinical condition that caused the family problem? Is what first and foremost thing that you should understand. If this problem has existed prior to the onset of the person's clinical condition, then you have to look into the genesis of what happened in the family. How was the family functioning? Is it that they're using this clinical condition as an excuse to have some family discord? So all that needs to be kept in mind. And I think it is important that we all look into the systems, look at their family background, because in India, there is the culture plays a very, very important role. Some cultures accept certain behavior. Now, who are we to say that to change that behavior? Because from border to border, the food varies, the language is different, the culture is very different. Now, we need to understand this culture of the individual and then devise our therapy according to it. And that is when it will work. If you say, yes, textbook has given me, now I'm going to do this, it's not going to happen that way. Yes, for research purpose, we need to have some homogeneity. We may take some things, but otherwise you have to tailor make it according to the family requirements. Thank you very much. Thank you, Arun, and thank you, Noor and Ashwath, Dr. Paneerselvam, for inviting me to be in this program. I truly enjoyed the presentation, and I think you carry out many more like this. Thank you.
Thank you, ma'am. Thank you for your great words from an experiential account, ma'am. Thank you. Now, Naveen can take up the session for a vote of thanks. Naveen? Yeah. Yeah, go ahead.
Yes, sir. Especially, I need to thank Dr. Pannisalam sir, Dr. Nurul sir, and Rashid sir to organize such a wonderful program. And the nutshell of the program has been comfortably delivered by Dr. Arun Selvaraj sir. And Madam's inputs also is inevitable in this session. So definitely the PG's attendance today is 125. So many PGs have attended. They have been benefited out of this program. So successfully, we are going to do so many programs like this. And in this forum, my sincere request is to all PGs kindly share this to our colleagues, and for the forthcoming programs also ensure your people also to be benefited. And
Thank you. Okay, so there are no other comments, then we can wind up the session. Thanks a lot.
Thank you so much.
Thank you all.
Thank
Thanks
you all.
for.
Thank you.
Thank you.